I'm drawn to the blood, the flight of a one-winged dove.
G'day, my name's Dave.
Hi, I'm Jesse.
And today we're going to be talking about the management of primary postpartum hemorrhage.
The strength of his arm.
As with any patient that is assessed and treated by ambulance personnel, a prompt yet thorough primary survey should always take place. In the setting of postpartum hemorrhage, the paramedic would identify the need to stop and manage life-threatening hemorrhage before continuing on to their clinical approach.
Depending on the severity of the hemorrhage, the paramedic may have to simply control the bleeding all the way to hospital. This may even be without progressing on to further aspects of the clinical approach.
With blood on my sleeve.
It's important to assess the patient to make sure that they've had a baby in the last 24 hours and also that they're bleeding into the genital tract above 500 mils to establish that it is a primary postpartum hemorrhage.
To ensure that the hemorrhage is not due to perineal tearing or other superficial lacerations, a visual inspection of the vulva and perineal areas will need to take place. It's important to gain the mother's consent before you do this. If you do notice that the hemorrhage is due to this, you can apply local compression, such as a towel or pad, to control the hemorrhage.
One of the best things that the ambulance service can do with this patient is to get them to definitive care as quickly as possible. So what we'd want to do is get them in the truck, loaded up, and on the way to hospital. We wouldn't want to delay that for anything. We'd also need to let the hospital know that we're coming and that they're possibly going to need surgeons and other gynecological services available.
As soon as you suspect postpartum hemorrhage, you want to be getting on the radio straight away and calling for Micah and any other crews to back up. This is because you may potentially have two time-critical patients in the mother and the baby, and it doesn't hurt to have backup anyway. The mother should be encouraged to empty her bladder. This assists with uterine contraction. So we've discovered that there's greater than 500 mils of blood loss postpartum. So the next stage is to check the fundus and see whether it is firm, i.e. it is contracted, or it is not firm. The equipment that will be needed is gloves, perineal wipes or washcloths, and pads, and towels as well. Step number 1, cup hand around the uterine fundus at about the level of the umbilicus. Then place the other hand at the symphysis pubis to stabilise the uterus. Next step is to rotate the hand gently at the fundal level, and you continue this massage until the uterus becomes a firm globe. It's important to make sure that you do not massage a contracted uterus. Observe for passage of large clots. Clean the woman's vulva and perineum, apply a clean perineal pad, and document the procedure and all observations. Misoprostol and oxytocin have the same effect as the endogenous hormone and assist with the contracting of the myometrial fibers. This causes the fibers to kink off the blood vessels.
If Micah are available, they would use oxytocin to induce uterine contraction. If they're not immediately available, the paramedic should administer 800 micrograms of misoprostol without delay. Gaining the patient's consent before we administer misoprostol is vital in Victoria, because this drug is not actually licensed for use in the setting of postpartum hemorrhage in Victoria.
Damn straight. It is important to encourage breastfeeding or nipple stimulation, which triggers the release of natural oxytocin into the system. The release of oxytocin assists in the contraction of the uterus. If the fundal massage is ineffective and hemorrhage is still continuing, the next step is to perform external abdominal aortic compression. This can be done by locating the point of compression just above the umbilicus and slightly to the left. Apply downward pressure with a closed fist directly through the abdominal wall. Effectiveness of this can be gauged by assessing for a palpable femoral pulse when the pressure is applied. It is worth noting that a firm pressure needs to be applied for this to be effective. Although this technique is not indicated in Ambulance Victoria practice, if hemorrhage does continue to occur, hospital practice and other pre-hospital providers around the world use the bimanual massage for uterine atony. This has shown to be best practice. Bimanual uterine compression massage is performed by placing one hand in the vagina and pushing against the body of the uterus, while the other hand compresses the fundus from above through the abdominal wall. The posterior aspect of the uterus is massaged with the abdominal hand and the anterior aspect with the vaginal hand. Bimanual uterine compression massage is performed by placing the hand in the vagina and pushing against the body of the uterus, while the other hand compresses the fundus from above through the abdominal wall. The posterior aspect of the uterus is massaged with the abdominal hand and the anterior aspect with the vaginal hand.
When a patient loses a lot of blood, they're at risk of going into hypovolemic shock. Tissue hypoxia is our major concern in these patients. Oxygen is rapidly extracted from the blood as the body attempts to bolster tissue oxygenation saturation. The body's compensation can only do this for so long, and there's a limited supply of oxygen in the system.
In order to give the patient a chance at regaining hemodynamic stability, oxygen therapy is initiated by a non-rebreather mask, aiming for oxygen saturations of 100%. Fluid replacement is vital to sustaining a woman suffering postpartum hemorrhage and should be done with blood products where possible, in order to enhance the patient's ability to carry oxygen to the tissues.
In the pre-hospital setting, the infusion of crystalloids is more readily available, and Ambulance Victoria's hypovolemia guidelines are just 20 mL per kilo when the patient is either tachycardic or hypertensive.
As with any patient, we will continually reassess against the baseline OBS to see whether there is any improvement or deterioration. It is important to notify the hospital with any suspected case of postpartum hemorrhage. This is to ensure that the correct team is waiting at the door when you arrive.
As is the case in all ambulance jobs, it's important that we are pretty thorough with our documentation, so make sure that you spend a good bit of time, whether it be at the hospital or back at the branch, making sure that you've noted down everything that happened, so that if you do need to look back on the case, you can recall everything that's gone on.
In this industry, it's important to debrief with your colleagues or your mates outside of work, someone who's willing to have a listen to what you're going through. Each person may be affected by a different type of job, so this sort of job has potential to have an impact on a person. It's always a good idea to relax and unwind after these sort of jobs, whether that's by doing sport or just spending some time outside, hanging out with your family, going for a run, having a beer with a mate. Just whatever works for you. Just to reiterate all our points, we need to follow the clinical approach and have appropriate PPE on.
We're wanting to assess the patient looking for a hemorrhage above 500 mils. We want to make sure that the bleed is not from the trauma of birth, such as vaginal lacerations.
Palpate the fundus to ascertain whether it is firm or not. If it is not firm, massage should commence. Massage the fundus until firm. If this doesn't work, bimanual uterine compression all the way to hospital.
When working in Victoria, instead of going for bimanual uterine compression, we'd look to get some pressure onto the aorta, trying to make sure that we stop the bleeding into the genital area.
Encourage the mother to empty her bladder or breastfeed and stimulate the nipples. This will help with the natural release of oxytocin.
If mica are available, they would administer oxytocin. If ALS are the only ones available, we would give misoprostol, 800 micrograms. Further to this, we'd want to be assessing the hemodynamic status of the patient, and if appropriate, we'd be treating for shock.
Again, we're treating for hypovolemic shock, giving fluids and high flow oxygen.
Of course, with this patient, we'd want to get them to hospital as quickly as we possibly could. And we'd want to let the receiving hospital know that we're potentially going to need surgery and gynecological services available.
Yeah, that was awesome.
My son, come tell unto me about cutting down yon hazelnut tree.
Yeah. G'day there. Hi there. Oh man.
Hi, today we're going to talk about... Hi, my name is Dave and this is Jesse, and today we're going to talk about the management of primary... Hi
there.
Hi, my name's Dave.
Hi, I'm Jesse.
And today we're going to be talking about the...
We're talking about...
Okay. Hi, my name's Dave.
Hi, I'm Jesse.
And...
Hi there.
Hi, my name's Dave.
And I'm Jesse.
And today we're going to...
Bonjour.
Hi, my name's Dave.
Hi, I'm Jesse.
Today we're going to be talking about the management of post... Let's do it again. Hi, my name's Dave.
G'day, mate.
When the sun and the moon shines in the North Hills and